PowerPoint, third case. Pramod, you will be able to present it? Huh?
Now.
Yeah, you just go ahead and present because I don't know whose mic is on. Go. Oh, your mic is not connected. Okay, so show the next PowerPoint slide. So this is a 43-year-old male who is having a recent...
Hold on, Shiva, we've lost your slides at the moment.
Are you hearing me? Hello, my audio, is it heard?
No,
okay, see, my audio is not coming to them. Hello? My audio has to be rectified.
Now we can see the slides.
No, but are you able to hear me, Shaq?
Not good.
No, there's a problem with the feed, Siva. Your voice is breaking up and the slides are flashing, so I'm not sure whether it's on our end or your end.
Ask him to find out whether the audio, the battery needs to be changed.
What not? Battery of what?
Could somebody pedal harder back there?
Can you hear me now?
Shiva, it's the signal from your end that's a problem at the moment.
Now we're looking at
I'm talking. Are you able to hear it?
Well, we can, but intermittently.
Okay. I think the problem with the battery or something needs to be changed. Can you change it?
What, your battery or computers?
This is Frankfurt for India. We're having a very bad video and it's flickering all the time, so please check your connections.
Whilst we're waiting, any questions?
Now it's gone.
Anybody or comments, Sachin?
Ja, dus volledig eraf. Ik weet niet wat mijn sessie staat.
Raising as a question, if the description of stenosis was predominantly at a muscular level, that single stent is going to be a problem, and it's a wasted valve. And whatever number of stents you put in with the muscular cuff of the infundibulum, they do fracture. I can see the point that the age of the patient, comorbidities, and other indications. But then, if you're doing a procedure, probably it would have made sense to have more stents.
This is Victor from Frankfurt for India. Are you still there?
Anywhere, I suppose.
I've got one with fragments embolized to the lungs, and so after that, I've tended to put covered stent if I was ever going lower down, because if it fractures, at least it stays.
Was that not a covered stent that fractured? If I remember that one, it wasn't covered.
I put it covered afterwards, yeah.
The other thing with that, Sachin, is if you're putting an S3 in, if you can get the S3 to be low, it should be the most robust stent that exists. So whether or not you can get the S3 with use a long stent to stabilize it, but put the S3 in the muscular bit, then that might actually hold.
Yeah, I think that you could prevent the stent from being in the valve stent from being in the part which will be compressed. So you have the luxury of putting it anywhere.
I am not.
And Zephyr, I think, is a cobalt chromium stent as well.
I don't know. It looks like an LD Max. It looked like an analog of an LD.
The other thing, if you saw the distal crown of the stent, it had already denatured with the Atlas, so you could see two rings completely separated. So, and that's not attached to anything now. So that's likely to embolize, I suppose.
We have a better feed.
Can you hear me, Shaq, now?
Okay. Shiva, we can see. Can you speak?
Can you hear us?
Yeah, I can hear you very well. Can you hear me?
We're not hearing you.
No, we can't hear you.
Okay, the audio needs to be sorted out. No, maybe this mic is defective.
Can't hear anything.
Okay, show the fluoroscopy so that they keep see. Okay, can you see the PowerPoint now?
Do you want to narrate?
And can you lip read?
Can you see the PowerPoint now?
We can read the slides, but can't hear anything.
See, the audio needs to be sorted out. Tell them to sort out the audio.
Yes. That's the region.
Amel, yeah.
Okay, go to Fluoro Live. Fluoro Live. Go to Fluoro Live, Ujjwal.
So tell
no
us,
need for PowerPoint.
show the next slide. Oh, right, okay.
Okay, Shaq, we are going live direct because the audio, there is a problem.
Steve, I'm not sure whether you're aware, but we still can't hear what you're saying, but...
Maybe you can get the slides back up very quickly so we read them.
Show the slides again.
That will save time.
Show the slides. Next slide.
So I just looked up the Zephyr stent. So it's probably more like the Palmaz XD Genesis. It's got the little connecting.
Right.
Okay.
It wasn't.
So now we can hear you.
Okay, now
think it
this is
expanded
a
just
transesophageal short axis view. Are you able to hear me, Shaq, now?
Yeah.
Okay, superb. So this is a transesophageal short axis view where the right upper pulmonary vein is draining into the lateral wall of the right superior vena cava. Next picture. And this is the long axial view bicaval where the left to right shunt is seen in the sinus venosus defect. Next slide. So this is the 3D en-face view of the transesophageal echo. Next slide. So there was the fossa ovalis was intact with no additional secondum defects. Next slide. So this is the 3D virtual reality. So can you run this movie? Okay. Next picture. So this is the virtual covered stent. Our plan is to put a stent of around 75 centimeters long and a diameter of around 22 or 24 millimeter. Next slide. There was an additional pulmonary vein which was draining high above, which we are planning to address. So what we are going to do now is get the additional pulmonary vein cannulated. Can you show lateral view? This right hand should be above. Okay. 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 Okay.
Oh, Shiva, quick question or comment here. Antigone,
I want a cardis. Yeah. Yeah, tell me.
With this procedure,
okay, come to APU.
TOE guidance essential or not?
Absolutely.
I'm going to show how without a TE guidance we can do this procedure.
We need to understand the defect very well. I'm all about VR and all of that, but I think we need a good TOE imaging here because that's going to guide the procedure. We need to understand the extension of it anteriorly, caudally, look at all the pulmonary veins and assess them before we start ballooning and putting stents in so we know what happens afterwards.
All right. Shiva, you're going to show without TOE, yes?
Yeah. Okay, go to lateral view again. Cordis is ready. Okay. Shaq, basically there is an additional pulmonary vein which is draining high above. So our plan is to protect that additional pulmonary vein and deploy. Go to lateral view.
Siva, how are you going to protect that upper pulmonary vein? I'm a bit confused. Are you?
I will show you. I'll show you.
Okay, good.
I'm now trying to cannulate that posterior additional pulmonary vein. This is azygos. This is azygos. Just it was adjacent to the azygos.
Trying to guess what you're going to do, and I'm very intrigued.
That's down the azygos, isn't it?
Yeah, that is azygos. I just entered, but when I turned into the AP view, it flipped out. So now it is a 6 millimeter additional pulmonary vein, which I am planning to cannulate, and then I'll show you how we protect it. I am going to use a hybrid stent, which will have an open end on the top, which will allow this additional pulmonary vein, and a closed end at the bottom, which will allow the main right upper pulmonary vein to be closed. I'm going to demonstrate that. Let me first cannulate it.
Okay, but if you cannulate it, then your wire is going to be behind the stent.
I'll show that, Zigarat. Just give me a second. I'm actually okay. The problem is this patient's right shoulder is dislocated, and so I am not able to abduct his shoulder. So the humerus
dislocated.
No. He had a past history of a dislocation. So
that should make it easier.
So the humerus is all across there. Okay, now I have cannulated. I'll now go inside.
I mean, I'm curious also, are you planning on doing angiography at all? Or is
yes, I will do it. I'll do it.
Right,
the moment I enter I will get everything. Okay, come to AP. Come to AP. Now get an angiogram connected to this main upper pulmonary vein. Okay, now, okay, now go to RAO, and I'm going to separate out. Okay, parallelly we can go. Is it a stiffened? Get the stiffened. I'm going to demonstrate an angiogram where I show all the three structures together. That's enough. Okay. Now get me this contrast. Okay. Now 1 second. Okay, the main angiogram gets connected. Come. Angiogram gets connected to the marker pigtail that is in the superior vena cava. The right upper pulmonary vein gets a sheath injection through the side arm.
Can you ask them to move your picture to top right?
My picture can disappear. Okay. I know that you always don't like to see my picture. Shaq.
Yeah, your sound is enough.
Okay, now hold it. Now you are going to inject the main right upper pulmonary vein. Pramod will inject the additional pulmonary vein and the pigtail will start. So the order will be first the pigtail should opacify, and then you will opacify, and then Pramod will opacify. Right, ready. So now shoot. Yeah. Shoot. Okay, now you see that. See, basically, Shaq, the pulmonary vein, the right additional pulmonary vein is almost draining at the level of the innominate vein junction. Freeze it. Freeze. Okay, you can now see that it is at the level of innominate vein junction. So it is quite high. So what we will do is, we will now, I want a Amplat superstiff guide
Before
wire.
that, a practical question, Shiva.
Yep.
What access? I'm assuming you don't have internal jugular venous access. Is that correct?
Yeah, balloon interrogation, we will do it. Now.
Shiva?
Yeah. Tell me, Shaq.
What access do you have?
Nothing in the neck. Everything will be from the groin. I'll show you.
Okay.
So currently what I have is a 18 French Cook sheath at the groin. Our anticipated balloon was 22 millimeter because the superior vena cava was measuring around 20 millimeter. We are planning to start off with a 22, or shall we go for a 24, Pramod? Okay. Okay, this is a 22. Okay, 22.
You're planning to interrogate with a balloon, yes?
Yes. So now while I'm interrogating, I'm going to have...
Whilst you're doing that, let me just check with a few. So if you present this case to your surgeons, and the surgeon says, I'm going to leave the highest right upper pulmonary vein
should not come out,
draining into the SVC and redirect everything else, what would you say to that?
It's a very small amount of lungs, so I don't think it would be clinically significant. So I think that would be the right thing.
Show me.
I think you might
on the
cause
top.
more harm by trying to use a lung patch to get that down the SVC over.
So you would close this sinus venosus defect,
Show
leaving that right upper pulmonary vein draining to the SVC.
Probably an accessory pulmonary vein.
Sachin?
I agree with that, and I'm pretty sure there are quite a few people walking around with one vein somewhere in their systemic veins. We don't
Okay,
even know.
Landra Krishwaya. So Shaq, what I have done is, I have advanced the superior marker pigtail, superior vena cava marker pigtail into the right jugular vein. and I have
What are
parked
you
it in
doing
the
in
right
jaw?
What's that?
No fillings. It's impressive.
What are you planning to do on the jaw?
Basically, I have got my marker pigtail up to the jugular bulb. So
Oh,
now,
right. Okay.
now what I'm going to do is, I'm going to have my Lunderquist wire
In the mouth.
in the upper part of the jugular vein. So now
The
I'm
ear.
taking out my marker pigtail. Okay. So now go to lateral view and confirm that my this catheter is anterior to the Mullin sheath.
So the question we were just discussing, Shiva, was if the surgeon says you'll leave alone that right upper pulmonary vein, meaning draining into the SVC, then what do you need to protect?
I mean, basically, we don't want to occlude it. The surgeon will leave behind that vein into the right superior vena cava. But here, we should not occlude it. I want to protect it, meaning I will allow it to drain into the superior vena cava. I will have a bare part of the stent. Okay, now I have got a 22 millimeter bib balloon across. So now what I will do is, I'm going to connect my pigtail catheter to pressure. Show the pulmonary venous pressure in a 20 scale. Reduce the level of sedation. He's too much sedated. He's having a lot of respiratory variation. Okay.
Siva, I know I'm sort of beginning to sound like a really annoying 8-year-old, but I still don't understand why you're going to have a catheter in that right upper pulmonary vein anyway. If it's at the innominate junction, you're just going to either have the bare metal stent crossing it and maybe have to dilate the cells afterwards, or you're going to land the stent just underneath it. I'm waiting for some sort of brilliant genius move you're going to make with this catheter, but I don't understand what you're doing there.
I will demonstrate it, Shaq. Gareth, just wait for a short while. I will show you what is the intention of that catheter. Okay, now you see that I have actually got the 22 millimeter balloon fully across. The pulmonary venous pressure is not increasing. Hold both. So now I'm going to disconnect this and connect it to the angiogram. We are going to see whether...
At this point, then, do you measure LA pressure as well as the pulmonary vein pressure?
The pulmonary vein pressure was 5, Shaq. So I was not very keen on measuring the LA pressure. I can easily measure it from the sheath. But it is 5 millimeters of mercury.
Okay.
Okay, now are you ready?
And how do you know... I'll wait.
Okay.
Okay.
Now you see that most of the pulmonary vein is now redirected towards the left atrium. We have to remember that I have a small catheter that is going parallel towards the superior vena cava, and that is not allowing me to completely occlude. Can you go to 4, like once again, I will just deflate a little bit. Okay.
And
now you reinflate.
What size balloon is that?
This is a 22. Okay, keep both.
And now can you measure it?
I'll measure it. Now I am going to make another injection. Ready? You are gone to how much? Go to 4.
As impatient as I am.
Go to 4. 4. Okay, 4. Full 4. Okay. Now ready for another angiogram? Now I have the same 22. Now I have given a much more like a full inflation. Let us freeze this picture. Freeze this when most of the pulmonary vein is now connected to the left atrium. A tiny amount that is
shunting to the right atrium. Yeah.
A tiny amount is shunting, but that I am having a parallel right coronary artery catheter that is going into that additional pulmonary vein. So I would presume this is good. Or do you want to try a 24 also?
Measure your balloon.
So that also will. That will.
It may be 20.
No, that will. The stiff wire is not causing the problem. Okay, now actually go further to about verse 3. Huh? No, 22. Okay, now ready for the last injection? Okay, I am actually convinced that most of the pulmonary vein is getting redirected to the left atrium. I will now show the left atrial pressure. Hold both together.
Are you measuring
left
Are you
atrial
measuring a right
pressure?
upper pulmonary vein and left atrial pressure simultaneously here?
Yes, I will do both now.
Point is that if the pulmonary vein pressure doesn't go up, then you don't need both. It's only if the pulmonary vein pressure goes up, then you need to know has the left.
You need to know what the LA pressure is.
Yeah.
I'll get both pressures now. Show the pressure big. Show the pressure big. 10 scale. 10 scale. The patient is a little bit over sedated, so you can appreciate that both the pressures are hugging each other. Can you see that?
Yeah.
Yes.
So there is no obstruction. So what our plan will be, so probably there is no need for a pulmonary vein protection in this patient. So now what we are going to do is, I will leave the Lunderquist there itself. Now deflate this balloon.
And
Fully
have you
deflate.
measured the balloon diameter?
It's a 22 millimeter. It's a 20.
No, but you might not have fully inflated it.
I inflated to 4 atmospheres, which is the full rated burst pressure of this balloon.
It's very difficult to measure then, isn't it?
Now I am taking out this catheter. Okay. Now this one fully deflated. Now you take out this balloon.
So
now I will
as
show
do
you
that,
what
Siva,
is the
then-
strategy.
Oh, okay.
What is the distance between the upper pulmonary vein and the, it's almost around 3 centimeter, right? Okay. So hold it here. Now get the hybrid Zephyr stent opened. Hybrid Zephyr stent. I'll show you the stent. Get a Merrill crimper. Take it out. Open. Just expand it. Okay. Now, sister, you have to give
I'm
some space for
assuming-
them to see. So
I'm
now,
assuming go on then.
so now this is the same 22 millimeter. Show the camera now. Show the camera. So this is the same 22 millimeter, 22 into 6. Now this is the hybrid Zephyr stent. So this has got a proximal. Here it is uncovered. Here it is covered. So the first step that I am going to do, Pramod, you need to upsize it. No, but then you cannot remove double.
How long is this? How long is the stent?
And how long? Oh, yeah.
This is 8 centimeter. 8 centimeter.
8. And that's the entire length or just the covered length?
The covered length is 64 millimeter, and the uncovered length is 16 millimeter. This is 16. This is 64. Are you able to see it? Yeah.
Yeah. And what balloon are you going to mount it on?
The same balloon that we used for the interrogation.
Which was 22 by
6. 22 by 6. So I will have a little protrusion here and there.
Yeah, the covering is obviously nice and robustly attached to that stent, just by the way you're able to pull it onto the dilator there. Siva, if you did that with a CP covered stent, you would have a
You'd have a bare stent.
Yeah. Yeah.
18 French.
Even
18 French.
No, the G armor is tougher than that.
Fine.
18 French will not take. What is the recommended sheath for this?
So what
This is a 12 French.
If we're doing that with a CP
12
or a
French.
G armor, we get a pair of
Plus
closed
5.
forceps and basically use
Plus-
those to increase the size of the stent so you can get it onto a big balloon, because I
Okay.
think doing that would rip the cover off for
So
sure.
now, okay. So now what we'll do is, Shaka, I have to now take out one of the guide wire from the pulmonary, the additional pulmonary vein, and I will recross, because I have to upsize this 18 French short sheath into a 22 French long sheath. So now I am taking out the 18 out. I'm going to the 22 because I am.
Okay. So you're delaying the groin and putting a 22 French long sheath in for delivery.
Exactly.
And I have to say, Siva, I think it was a bit cruel of you teasing me like that. You could have just told me at the start of the case you were going to use a hybrid stent, and then I wouldn't have got all impatient and excited. You could just said.
And
Get me-
I'm
get
going
me
to
a-
rephrase.
Get me
I'm
a
gonna
5 French
rephrase my
RCA
question
guide catheter.
again. Shiva?
Yes.
I may have missed it again, but I'll rephrase it. What is the balloon that you're using in terms of, I know the diameter and I know the length, but what
22 into 6, and that is going to be used for mounting an 8 centimeter stent, which is 2 centimeter longer than the actual balloon. But the shoulders of the balloon are going to allow me. Can you get me the thermo wire?
Let me rephrase the question. What company makes the balloon?
This is the same ZMED balloon. The same ZMED. Not a ZMED, it's the
That's
bib
all I
balloon.
wanted to know.
It's a bib.
Yeah, it's a bib.
Just now I used the bib, the same bib, new med. Thermo wire inside.
We're all taking the piss here, but
Okay.
I would have still been doing
Now you
first
see
case,
this.
I would have messed it up.
Now you see this assembly. What I am planning to do, Pramod, you just adjust it. Okay, now show this other camera. Okay, so now what I am doing is, I am exiting my guide wire here. So this is now the catheter. So I am going to have this portion on the superior vena cava, and the side catheter will ensure that I am within the pulmonary vein. So now I am going to take out this catheter, get this 5 French guide catheter inside.
Can you ask somebody to
move? You have to move. Sister, he's on the camera. Yeah. Now get this inside. Get. Yeah. Get no, not the back end, the front end. Come on, get the. Get it now.
No, we haven't.
Come get it. The sheath is, what is the sheath?
Yeah.
I mean the Lunderquist went out. Okay.
Disconnect here.
So now I have got a guide catheter that is coming out through the side arm. Now I will take this wire out. Take this wire out. Take this wire out. Okay. Take this wire out. Now get me the 22 bib balloon that we already opened. Deflate this balloon. Fully deflate. So now what I have got is that bib balloon is now having both the bib balloon and the guide catheter are together, but the guide catheter is exiting out proximally. Can you see that track?
Yep.
Okay. So now I am going to crimp this whole assembly down. Already I mentioned to you that it is only a 6 centimeter. So now I am using a crimper. Get me a small short guide wire for my bib balloon, the short guide wire.
Shiva, would you protect the guide catheter with a guide wire or something during the crimping?
Not during the crimping, but I will do, because but primarily I will be using it. The guide wire will not.
No,
I want
you'll squeeze the lumen.
The guiding catheter is braided, no, so it will not. Okay, now get me a thermo guide wire. No, that is not going, it's a 3/8. So get a thermo guide wire into this bib balloon. Okay, Kevin wants a wire to protect the RCA also. Get another thermo, short thermo. Normally I don't do it, Kevin, because it's a braided catheter, it doesn't collapse, whereas there is no braiding for a Z-mid balloon or a big balloon, so that one I protect. But anyhow, today now I will protect both. Get me a thermo.
While you're doing that complex prep
Okay,
work,
now
Siva,
get the next.
John
next
Carroll
thermo.
just asked the question about what evidence we have for this, and unfortunately, worldwide, we've got a registry that Eric Rosenthal's running that a lot of us have contributed to, and some tentative plans to get some studies that might give us evidence for approval in either the US or Europe. But at the moment, we're very much relying on good multidisciplinary discussions and the surgeons sort of acquiescing and agreeing with our plans, because we're still in a completely evidence-free zone from the point of view of this technique in superiority to surgical closure. But hopefully that'll change over the next 5 years. But at the moment, we're in sort of no man's land.
Gareth, I think you may be aware that we recently got our first 100 patient experience published in JAC in the most recent issue. I think you would have seen that.
Yes, and I think that sort of publication is really helpful. But as you know, unfortunately, with regulatory bodies, that only goes so far. But that's still really helpful to have something as large as that out there, Siva.
Yeah, it doesn't persuade the FDA or European Union to approve these, so
that is
they
ready.
still need their own studies. I think.
Okay. Now you get me the guide wire here. I will have to again recross, if possible, the stiff. No.
It's also a challenge in that there's a lot of heterogeneity.
Correct. So get another thermo wire.
Right. So there's no single device that anyone's really relying on.
Okay, now you see here, now I am using the crimper. You show this camera. Show, sister, move out. So now what I am going to do is, I am crimping this whole stent.
Yeah, exactly.
Can you see that? Now
Yeah.
I have crimped both together. Now get this, sister, this right coronary artery guide catheter out. That catheter out. Yeah, take it out. No, take the wire out. Yeah, take this other wire also out. Give that wire to Dr. Pramod.
Siva, you've got to be pretty confident about the length of the guide catheter as well to make sure you're going to be able to bury that into that pulmonary vein.
So tell me that again.
I said you need a good level of confidence about the length of guide catheter that you have at the end to make sure that you can bury it in the pulmonary vein completely.
Yeah. Now I have actually sheathed the whole thing. You see that this amount of guide catheter length is there somewhere around 5 centimeters out. So that is good enough for me. So this is now the assembly has been made. So now what we are going to do is, we are going to recross that vein which I had actually taken out. Show AP view.
Only a bit of azygos again.
Yeah, this is azygos.
That's it. Oh no.
Check angio. Come, get me one contrast cup. Take this out.
So, Shiva, no rush, but we've got about 5 minutes.
That's too short a time, Shaq.
We'll
Okay.
give you an extra 1 minute then.
But
Yeah.
you've only got one more
Extra,
case after this.
extra 5 minutes. In no matches, they give extra 1 minute. It's not a T20. It's like a football. 10 minutes. Actually, Shaq, after this, I have to go to the blue room. Sorry, this is what room? This is red room. I have to go to the
This is
blue
red.
room for another case from the other lab. Okay, now take this out.
Oh my God.
Take this
So
out.
you're not gonna eat, are you? You haven't eaten since
In
morning.
another 30 minutes, I have to be in the airport to take my flight. I have to reach Frankfurt tomorrow morning. Okay, now get that.
Steve got a G-tube and a suprapubic catheter last year just to increase his efficiency.
Okay.
It's true
See now,
dedication to the
now
profession.
here, they make this big screen, camera big screen. So now I have both guide wires coming out. The blue is the amplat superstiff that is in the right upper pulmonary vein, and the white is the Lunderquist that is in the superior vena cava, jugular. So now, so both are coming together. So now I'll show you the structures. So this is the guide catheter in the amplat superstiff, and this is the
balloon.
So both, Pramod has got control over both now. So now I am entering the sleeve. Now I am advancing both the stents up. I'm taking out the sleeve out. So the sleeve has come out. Pramod, the guide wire needs to go in deeper. So now the right coronary guide catheter is going to go into the superior vena cava. So this is the position. Now I'm going to make from the side arm of this guide catheter, put a 2 Hebost here. 2 Hebost.
One of the advantages of TOE, I know you're not doing it, is that you can see the bottom end of the defect and know how much overlap of the stent there is to the septum.
We made some calculations. I think Pramod has done a lot of virtual reality stuff on this, and he has decided that a 74 millimeter stent is good enough, and we are taking a 79 millimeter, almost 80 millimeter. Okay, enough. Okay.
I think it sort of feeds into the whole idea. If you're incredibly comfortable with virtual reality planning, then it can, you know, I wouldn't want to use the word supersede, but it can, you know, it can avoid the need for a transesophageal. I think most of us would want to depend on the transesophageal echo, but I think as people get more familiar with virtual reality, then, you know, you learn to trust it and make it your primary imaging modality. This is just a pretty impressive level of confidence.
Actually, I'll tell you one story, Gareth. Way back about, say, close to 20 years before, when I used to tell that in all cases of atrial septal defect, I will be doing a transesophageal echo. Ziad used to tell me, come to RAO, Ziad used to tell me that transesophageal echo and anesthesia is a major problem in the United States of America. And so normally, come give 10 at 15 there. So normally he will be preferring not to do, but to use something like an intracardiac echo. The basic dictum is transesophageal echo involves anesthesia, and so now what we are doing is, you see that is that additional pulmonary vein. So I am putting it in such a way that that additional pulmonary vein is covered by, is left bare. Okay, now go to lateral view and just confirm that our stent is anterior to the Mullin sheath. So I am clearly anterior. So that means we are safe. Okay, come back. So now I am going to unsheath the
I
Go
think
for a
this is the
full
bit that
inflation.
Going for inflation.
I think this is the bit that I would want transesophageal echo for this bit, because you've distorted the anatomy quite a bit with the wire and sheath, and I'm not in any way saying
4
you
atmospheres.
shouldn't do this, but I would want transesophageal
Fair
echo.
enough. Enough. Stop there.
Because it's really
So
the bottom
fluorostore,
end that
fluorostore.
you don't want popping across.
Ready? Okay. Now stop this. Deflate this.
The reason why I didn't think it was a big balloon was because it's what the inner bit
Fully
wasn't
deflate.
inflated.
Fully deflate. Now this is a short balloon shack. So I'm going to now come back and inflate the lower end. I am pretty secure because my guide wire is now holding the other guide. So
Yeah.
now I am little bit coming down. Now inflate it, Pramod.
It's still quite high.
No, but
Okay.
inflate it.
Okay.
I will progressively inflate. Actually, we are slowly getting each part of the stent inflated. Inflate.
No, and it's a good point. You've got more security because of that additional wire, so that
Correct.
gives you a little bit less chance
Correct,
of pulling
correct,
it down.
correct. Inflate full.
Very clever.
3, 4.
4.
Yeah.
Okay. Deflate. Fluorostore. Okay. Now fully deflate. Fully. No, full. Fully deflate. Now we are supporting the stent with the lower end of the sheath. I am getting the balloon inside.
Very nice.
You give a forward push. Yeah. Give a forward push. Okay. Now I am go up, Pramod.
Going.
Go up. Go up. Full inflation. Full inflation.
3, 4, 4.
4?
4, 4.
Okay, just stay there. Okay, ready for an injection? Shoot. Okay. This is with the full balloon inflation. You are okay?
Yeah, I'm ready.
Okay.
Ready,
Now
set.
deflate.
Summary 5.
Fully deflate. Now I will come marginally lower. Push it. Okay. Now inflate. 1 second. Inflate. Okay. Inflate. Full inflation. How much?
4, 4.
Okay. Deflate. Deflate.
Yeah.
Now, at this point, I take out my guide catheter's guide wire. Now I am going to inject in that additional pulmonary vein to show that it is draining into the stent. The bare
You've got
part
2
of the
minutes, Shiva.
that is including that 10 minute additional ball time, that extra time that okay.
And
Now come to
more.
RAO, quick. Come to RAO. Yeah, more RAO. Okay. So now, this is that
nice.
additional stent. Now come to AP. Ready for angiogram on this pigtail. Ready?
And if they could move your picture up top.
What shack?
Yeah, look.
Do you need a transesophageal echo?
That looked really good, yes.
So there's
Brilliant.
yeah,
And
well done.
I will give you simultaneous LA and PV pressures
you
now.
could do final pressures.
I'm doing that. Just give me a
Okay,
second.
Shiva,
We're going to pack up so everybody can get a coffee, Siva. But listen, on behalf of everybody, I think we need to thank your team because the way they work around
Gareth, there is an important learning point here. Restrictive LV physiology. Just hold on. Just a second. It's an important point.
The LA pressure's gone up now.
No, I'll show you now. Once again.
All right.
Now show both pressures. Okay, there is no gradient between the two. Okay, but the LA pressure is give Lasix 40 milligram IV, one dose. Show the blood pressure now. I'll show you the blood pressure also. Actually, the patient is fully conscious, just on little bit of like sedation. Okay, yeah. Show the blood pressure. Show the blood pressure marginally high. So get him Lasix one dose.
Yeah.
40 milligram.
So you're just demonstrating the fact that there's some restrictive left atrial or left ventricular physiology, and both the pulmonary vein and the left atrial pressures have gone up, which hopefully will be accommodated over a period of time with some diuresis.
All right, Shiva. Yep, well done.
So I actually I told that I have one more live case in another room. So thanks for all the good audience. As usual, Shaq has always been guiding me like with all the technical steps. It was a pleasure to have got the live cases. I would like to thank my entire team, Dr. Pramod, Dr. Srija, Dr. Sridhar, Arun, Raghu, all the nurses, all the intensive doctors. Dr. Uday has been staying with managing the sedation. So thanks a lot, and see you in the blue room now.
Yeah.
Okay, thanks to everyone. Thanks to the panel and the audience, and let's get a quick cup of coffee and get back up here.